Hello, good morning to you all. My name is Ahmed Azhar, and I'm here to present high-flow arteriovenous malformations, Mansoura experience, long-term results. This work has been
Please raise your voice.
this work has been previously done under guidance and the supervision by Professor Ihab Saad, Professor 𝗘𝗴𝗆𝗀، Professor 𝗘𝗴𝘆𝗃𝗀𝗃, Professor Mohammed 𝗟eci and Dr. Khalid Musa. This is my disclosure. Vascular malformations constitute one of the most difficult diagnostic and therapeutic enigmas in modern medicine. These are one of the various congenital vascular malformations since birth. They are resulting as a direct communication between different size vessels or through an abnormal vessel meshwork as the nidus. These lesions are specifically defined by shunting of high velocity, low resistance flow from the arterial element to the venous element. The aim of our work was to evaluate the safety and efficacy of the endovascular management of these high flow AVMs by embolization sclerotherapy and doing a long-term follow-up. So the presented work was done at our Mansoura University Vascular Surgery Department and the Angiographic Suite in Radiology Department. Included 18 cases from December 2015 to November 2020. We excluded intracranial arteriovenous malformations and those with hypersensitivity for the angiographic dye. Our clinical examination depended on the clinical classification of 𝗘𝗴𝘆𝗽. These are examples. Our investigation started with Doppler ultrasonography that confirmed areas of AV shunting with increased peak systolic velocity and ectatic veins showing arterialized flow. Next, we did CT angiography. It is of course the gold standard for the diagnosis of arteriovenous malformations, and it's correct. And as you can see, we can by the CT angiography classify these according to YACS. Depending on that, we can find a strategy for a better treatment plan. These are examples of the cases we have witnessed. Anesthesia usually was either local or general. Access was transfemoral or transbrachial. That is for the arterial access. Our cases usually had single access when we had to embolize the arterial side of the nidus. We had double access when we needed to do a venous access as well, especially when venogram revealed the retrograde flow from the dominant outflow vein. This is we do an initial flush arteriogram to map out the arterial anatomy. Then when the selective catheter was in position, we introduced the microcatheter and then dye the nidus and find out the lesion. Once we are exactly in the specified position, we inject 18 onyx. These were performed repetitively until there was serial negative roadmap imaging. Or until there is a major reflux towards the parent artery. This is an example of our work, a plantar arteriovenous malformation. With the microcatheter in MHB and onyx embolization in MHC. So usually when there is a reflux in the parent artery, we used to hold for a few minutes and then re-inject once again. This is called the reflux hold re-injection technique. Some cases we used 𝗔𝗀𝗃𝗃. These were in enormous arteriovenous malformations with high flow fistulas. A mixture of N-butyl cyanoacrylate with lipidol with a concentration of 1:1. Cases where we used alcohol, we used it according to the body weight, less than 1 milligram per kg, and was mainly used as a direct puncture into the nidus. We could be followed by with or without distal compression. Follow-up evaluation was based on physical examination and radiology, Doppler after 1 month and CT angio after 6 months. Mean follow-up was about 26 months. All of our cases are presented with pain and swelling, and half of them, present with bleeding and disfigurement. Stage 2 and stage 3 represented most of our cases with 55 and nearly 45%. Overall success was achieved in 89%. Locations were various, mostly involved the left mandible and the right hand. Many various complications, transient ischemia, ulceration, gangrene, scars. So one of the example of our cases is a lumbar AVM. This is a preoperative CT angiography, intraoperative angiography, pre and post embolization, and surgical excision later on. Second case is a hand AVM. This is the embolization, and there is a reflux in the image, in the last image. Follow-up was by pulse oximeter. Third case with the mandibular AVM. It was complicated, as you can see here, and we did transfemoral as the first session, and the onyx embolization. Post CT, there is some, right? So in conclusion, 𝗙𝗏𝗀𝗃 therapy appears to be a safe and effective intervention. Onyx provides controlled embolization. Combination approach using all three routes, transarterial, transvenous, and direct puncture, is recommended. A multi-session endovascular therapy is preferred. Every effort should be exercised to minimize the risks of 𝗙𝗏𝗃 therapy during each session.
Thank you
very much.
Thank you, Dr. Ahmed. I have a question. How could you classify the high flow? What is the classification you based on this paper?
It's based, the high flow AVMs, we classify them according to AX classification, the new one, into stage 1, stage 2, 3A, 3B, and 4. This is the radiological, and clinically we classify them by Schobinger classification to stage 1, 2, 3, and 4.
And what is the study design of this paper?
The study design, it was an interventional study from December 2015 to November 2020. It's a prospective
prospective
study.
or retrospective?
It's a prospective study. These are the collective results of our work.
Dr. 𝗟𝗏𝗃 will ask you about the indication.
What is the indication to attack by endovascular intervention the AV malformation? And what are the limits? What are your inclusion criteria to do that?
We included all cases of arterial venous malformations that are symptomatic. In case of
Symptomatic, what do this mean?
by pain, swelling, bleeding, disfigurement, tissue destruction. We excluded intracranials and those with hypersensitivity to dye.
Okay.
Thank you very much.
Thank you very much.